not chairperson, but chairperson will be introduced by our dynamic secretary, Professor Partho Kormokar. Now, Partho will introduce the chairperson of today, who is head of the Department of Medicine, and he is also an endocrinologist of National Medical College, Calcutta. Now, Partho, please introduce today's chairperson.
Thank you, Professor Sarkar, uh, for giving me this opportunity to introduce a very knowledgeable endocrinologist as well as knowledgeable internist, and he is a good friend of mine. He is none other than Professor Dr. Solil Pal. At present, he is attached to National Medical College as HOD in the Department of Medicine. So I think, and at the very outset, I also express my heartfelt gratitude on behalf of API ICP West Bengal chapter to both our chairperson, Dr. Paul, as well as our speaker, Dr. Rana Bhattacharya, for finding out some time for this masterclass from their very busy schedule. So, with this short introduction of Dr. S. Paul, I hand over the mic digitally to Professor Paul to introduce our speaker, Dr. Rana Bhattacharya. Over to Dr. Solil Pal.
Thank you,
Please
Patula.
start.
Thank you, Patula, for your good words. It is my pleasure to be here in this masterclass as chairperson. Thanks API West Bengal chapter and ICP West Bengal for inviting me in this masterclass. This is a very interesting topic. Thyroid disorder is probably the commonest endocrine disorder during pregnancy, and often there is some dilemma about or decision-making problem, and what physicians should know. For that, this topic is chosen by the API teachers. And topic is thyroid disorder in pregnancy, a case-based discussion. And speaker is one of the best thyroid specialists in the city of Kolkata, Dr. Rana Bhattacharya, at present attached to Medical College, Endocrine Department as Associate Professor. I request Dr. Bhattacharya to start his deliberation. Over to Rana.
Thank you, sir. Thank you so much. Thank you, Team API, for this opportunity, and all the senior members who are present there, many of my teacher and senior colleagues. So very good morning to all of you and those who are listening in, of course. So we'll discuss today, as Sarah said, that one of the commonest disorders in pregnancy is the thyroid disorder. I think really it's the second most common, followed by possibly diabetes in pregnancy, including GDM. This is the second most common problem during pregnancy, and there are many facets of it. And it's an interesting diagnostic and therapeutic challenge sometimes. So we'll discuss few of the cases. But before going into the case, let's just have a very brief overview of some or rather physiological changes that occur in thyroid function during pregnancy. So this graph actually shows that in the first half of pregnancy, the growing fetus is dependent on maternal thyroid hormone. And from the early second trimester onwards, fetal thyroid gland starts producing its own thyroid hormone, which is also supplemented by the maternal thyroid hormone, which crosses the placenta from second year onwards. However, with a growing placenta, more and more thyroid hormone gets degraded in placenta, and therefore the fetus becomes more dependent on its own thyroid hormone. And with advancing pregnancy, there is increase in iodine clearance as well. In addition to those, there are changes in the thyroid function which occur normally in a pregnant individual. So what happens first, that initially there is after conception, there is gradual increase in HCG production. So with the production of HCG, what happens that it cross reacts with the TSH receptor, So it works like TSH in a very high concentration, and a high concentration of HCG is very typical of pregnancy. So with time, there is increasing secretion of HCG, which plateaus somewhere from end of the first trimester onwards. And this increased HCG causes increased production of T4. So there is some increase in free T4 as well as total T4. And as there is increase in T4, there is corresponding reduction of TSH in the same time point, that is in the first trimester. What happens after that? After sometimes the body reaches a equilibrium. So the free T4 level gradually becomes normal and the TSH level also gets normalized. But what happens to total T4 here? As you can see here, this is the level of thyroid binding globulin and this is the level of total T4. Now those two things increase parallelly because with the increase in binding of thyroid hormone, the total thyroid hormone in the circulation remains high throughout pregnancy from second trimester onwards, despite normalization of free T4 level. This is a very important concept when we discuss the various abnormalities of thyroid function test. This has very important connotation on the interpretation of the test. And that is the reason why we have our trimester specific reference ranges for pregnancy. So the usual range that we have that is given by the lab may not work for your purpose. There is another important thing that throughout the world it has been seen that there is some variation of thyroid hormone concentration during pregnancy, and it also depends on the platform in which it is assayed. Now, this is the reason why American Thyroid Association and other thyroid associations, they recommend to have your own data from your own population regarding what is the normal range of thyroid function in pregnant individual. So for that, we generated our own data from the patients of West Bengal, and this has been published in Indian Journal of Endocrinology and Metabolism a few years back. As you can see here, these are the normal ranges of TSH. This is the ranges of free T4 and these are the ranges of total T4 and total T3 during pregnancy. And all those women did not have any thyroid disorder. All are iodine sufficient. They did not have any thyroid autoimmunity. But what you will do if you do not have your own data? Now there is another easy way out, that from the in the first trimester, you just reduce the upper normal range of TSH by 0.5 and reduce the lower normal range by 0.4 micro IU per ml. So if you just reduce the upper range and lower range by these factors, then approximately we'll get the trimester specific reference range, particularly in the first trimester. However, from second and third trimester, this gap is gradually seen to be reduced and TSH typically turns towards the normal range in the third trimester. So this is a rough estimation by which you can assess the thyroid function. You can interpret your thyroid function test result. Now, as I've said, there is increase in total T4 with pregnancy. So which test to use? Of course, our common sense says that free T4 is a better choice because there is no interference from the thyroid binding globulin factor. However, there can be some assay problems in the commercially available assays that we have. So therefore, an alternative is you have a value of total T4 with you, particularly in the late second and third trimester. and you have a normal range for non-pregnant individual. There, what you will do for the total T4 level, to get the what should be the T4 in the late second and third trimester, you just multiply it by 50%. You can increase the level, the range by 50%. So say if the normal range by the lab is given of total T4 between 4 to 50, 4 to 12 nanogram per DL. Now, what will be the normal range of total T4 in the third trimester? So, 4 plus 50% of 4, that is, it will be 6 to 12 means 12, 50% of it is 6, so 18. So, the normal range will be 6 to 18. So, that's how you will adjust for total T4. Now, with this background in mind, let's move into the disorders of thyroid. Now, I will focus mostly on hypothyroidism and hyperthyroidism. I won't go into details of the thyroid nodule and thyroid tumor. If anyone is interested in that, we can discuss that during the question and answer session. But what I felt that it may be less useful to the internists. That's why I omitted this from the discussion. So starting with hypothyroidism in pregnancy. Let's start with two cases as this is a case-based discussion. So a 32-year-old primary gravida in first trimester of pregnancy and TSH is 12, the normal range is 0.4 to 4 and free T4 is 1.1, which is within the normal range. Now, as we discussed, we can use free T4 in the first trimester. So what does this patient have? Does she have subclinical hypothyroidism? Does she have overt hypothyroidism or something else? So just you can note down your answer. If you have a pen and paper with you or on your phone, we'll discuss it at the end. The second patient, a 29-year-old lady in third trimester of pregnancy. TSH is 1.1, which is within the normal range, and free T4 is 0.7 nanogram per DL, which is lower than the lower limit of normal. This is the normal range, 0.8 to 1.9. So this is the free T4 range, 0.7. The normal range starts from 0.8. So what does this patient have? Central hypothyroidism, subclinical hypothyroidism, or something else? Again, you just note down your answer. Please cross-check when we will get back to these cases. So we say that pregnancy is a stress test for thyroid because a thyroid which is apparently working normally in the non-pregnant state can develop or can prove to be insufficient to produce adequate thyroid hormone during the stress of pregnancy where there is increase in demand in thyroid hormone production. So how hypothyroid is the disorders of hypothyroidism, they are defined. Now the definitions are a bit different from the non-pregnant individuals. In pregnancy, we say the patient is having overt hypothyroidism whenever the TSH is more than the upper limit of normal and free T4 is low. So that is called overt hypothyroidism. Okay. When TSH is more than equal to 10 milliIU per liter, irrespective of FT4, of course, the FT4 can be normal or low, not high. So FT4 is either normal or low with a TSH value more than equal to 10, we'll consider this as overt hypothyroidism. So this definition is different from non-pregnant individual. So what is the subclinical hypothyroidism in pregnancy? When the TSH is between upper normal limit and 10 milliIU per liter with a normal free T4 concentration. Now, this upper normal limit means the pregnancy specific reference range that you have. So, what are the causes of hypothyroidism in pregnancy? Three most common causes are autoimmune, iodine deficiency, which has become less common nowadays, particularly in our areas, and third, the result of treatment of hyperthyroidism that can be following following radioiodine therapy or with antithyroid drugs or following thyroidectomy. Total thyroidectomy due to other causes, whatever causes it may be thyroid cancer or other causes, that will also be considered as one of the important cause of hypothyroidism in pregnancy. So once, as I've said, discuss the various types of hypothyroid dysfunctions. So you have to interpret it accordingly, that we have already discussed. Now, once you diagnose the case as having hypothyroid, now how to go about treating it? Now, first of all, you need to decide whom should you treat. Okay, so whenever there is overt hypothyroidism, then you should treat, and your target TSH. Now, this is again, I will discuss it in two different headings. First, once a person who is known to have hypothyroidism is trying for pregnancy, and in the second slide, I will discuss the patient who is pregnant detected to have hypothyroidism. Okay, so this is the situation where before pregnancy the patient is having hypothyroidism and she is trying to conceive. Now, in this situation, if TSH is more than 10 or there is overt hypothyroidism, then ideally you should treat the individual, and the target TSH should be less than 2.5. This is important. There is no doubt about it. It's a very strong recommendation from all the bodies around the world. Now, if the patient is having subclinical hypothyroidism before pregnancy, but TSH is less than 10, you may or may not treat. But if antithyroid antibody is positive, we usually treat those patients. So anti-TPO positive with TSH less than 10, but it's more than upper limit of normal, we usually consider treating. And again, the target is less than 2.5. When the TSH is within normal range and the person is not on levothyroxine, so there is no indication for giving levothyroxine in these individuals before pregnancy. Okay. The fourth is situation that thyroid, the TSH level is within normal limit. The patient is a known hypothyroid. You are treating her with levothyroxine, but the TSH is normal. So in that situation, you need to do two things. Number one, please ensure that the TSH is less than 2.5. And number two, once the person becomes pregnant, you should increase the dose by 25 to 30% as soon as preg color test becomes positive. What I do personally, I instruct my patient that if you become pregnant, you increase the dose yourself. One of the easy way to do it is just to ask her to take 2 extra levothyroxine tablets per week on top of her usual dose once she becomes pregnant. And then I ask her to report back to me. So this is about how will you treat a person who is known to have hyperthyroid before becoming pregnant. Now, when hypothyroidism was detected first time during pregnancy. Now again, if there is overt hypothyroidism, now here, as I've said, that the definition of overt hypothyroidism during pregnancy is a bit different. So if FT4 is low and TSH is high, or FT4 is normal and TSH is more than 10, we'll call those patients is having overt hypothyroidism. We should start levothyroxine as soon as possible. There is no doubt about that. Now, if the person has subclinical hypothyroidism, with antithyroid antibody positive, we usually start treatment. Okay, so you should strongly consider treatment. However, in subclinical hypothyroidism, if antithyroid antibody is negative, you may or may not treat. Again, that depends on you. So sometimes we feel the risk of giving a bit of extra thyroid hormone may not be that harmful, although we do not want to uh, cause overt thyrotoxicosis with levothyroxine, because that is known to be harmful again. So usually we consider treatment. Okay, so it's a soft point. Now, when the TSH is normal, however, it's more than 2.5, and antithyroid antibody or anti-TPO is positive, then we may consider treatment. Okay, so here is a situation where despite having normal TSH, we may consider treatment, particularly when there is a history of recurrent abortion. However, the evidence that showed is very contradictory, so it's not a must that you must treat here. It's again a bit of a soft point. So if a person is having a history of recurrent uh, first trimester or second trimester miscarriage, then you may consider treating this patient if the person is anti-TPO positive. Now, sometimes you get a situation where the TSH is normal and free T4 is low. This is a typo. This is not LT4. This will be FT4. So this situation is called isolated maternal hypothyroxanemia. Now there are some studies where it has been shown that in first trimester, if a lady has a isolated maternal hypothyroxanemia, there can be some adverse pregnancy outcome. However, there is no benefit in treating those individuals with levothyroxine. So the only course of action is follow-up. So close follow-up with this individual. You do not need levothyroxine in this situation. Another point to add, if the person is anti-TPO positive and TSH is more than 2.5, as I've said, you may not start treatment. However, the person who are anti-TPO positive So these individuals, even if they are not treated, should be closely followed up with thyroid function test up to 28 to 32 weeks of pregnancy. Okay, now we have decided upon whom to treat. Now the question is with what? Now, as you all know, the treatment of hypothyroidism is relatively simple. It's just levothyroxine orally, and we typically start with the doses around 1.6 to 1.7 units per 7 micrograms per kg body weight, and usually our target is to keep TSH value within the trimester specific normal range. And during pregnancy, we tend to have a very frequent follow-up. So typically we ask to do thyroid function every 8 weeks, and in unstable patients with unstable TFT, you can do it every 4 weeks as well, till 28 to 32 weeks. And then you maintain that dose until delivery. Now, if the patient is a known hypothyroid before pregnancy, then after delivery, revert back to that pre-pregnancy range, pre-pregnancy dose. And uh, either you continue with levothyroxine in a patient known to be hypothyroid, or detected first time during pregnancy, you stop it at delivery. Whatever may be the situation, just retest the thyroid function 6 to 8 weeks after delivery. This is very important. Unless you instruct the person regarding this, they may forget because of the issues with the newborn and all. Okay, so now coming back to our patients that we discussed, 32 weeks primary in first trimester, TSH 12 and free T4 1.1. Now, as we discussed in our previous slides, that as TSH is more than 10 in the first trimester, so we'll consider the patient is having overt hypothyroidism, and we should treat the patient with levothyroxine. Okay. The second patient or second individual in third trimester of pregnancy, TSH is 1.1, free T4 is 0.7, which is lower than the lower normal limit. So this is a situation, as we discussed, is called isolated maternal hypothyroxanemia. So this is a situation where we should not treat, but we must the patient is already in third trimester, not need to do anything. Just after 6 weeks after delivery or 8 weeks after delivery, we should check the thyroid function again. Okay, so I will conclude the discussion regarding hypothyroidism by saying that hypothyroidism is a very common clinical problem in pregnancy. There can be adverse maternal and fetal outcome if hypothyroidism remains untreated, particularly if hypothyroidism is overt. And as I've said, there are many nuances, many difficulties in interpreting thyroid function test. So you have to be aware of that. And the cutoffs of diagnosing hypothyroidism and treatment targets may be different from the non-pregnant individual. And you should monitor more frequently. And we should not forget the patient after delivery. So postpartum monitoring is extremely important. The treatment is very easy and very rewarding. So we must start treatment and monitor appropriately. There are some areas of uncertainties, as I've discussed, with different values of PSH and anti-TPO positivity. So better to use your clinical judgment to that. And of course, there is a scope of further research. So this is all about hypothyroidism in pregnancy. Now we'll move over to the second part of our discussion, that is hyperthyroidism. So over to our chairperson, whether should we stop there and take some questions, or we should proceed to the next section straight away?
And I think
No, continue.
continue.
Okay, thank
Continue.
you,
We'll
thank you,
discuss later on.
thank you, thank you. So as our chairperson, coordinators all have suggested, so we'll continue the discussion here. So we'll move over to hyperthyroidism. Now, just like hypothyroidism, let's discuss some of the cases here. A 20-year-old lady, married for 1 year. She came to us with a LMP around 11 weeks back. And she has been referred for altered thyroid function test. This is the report of thyroid function test. The total T4 and total T3 both are high and TSH is low. So what is that? Now, as we have discussed in our previous section, that there is some physiologic changes in pregnancy. So in first trimester, there can be slight rise in T4, both total and free, and there can be drop in TSH. So this picture is consistent with normal first trimester values. Okay. So this is a normal TFT in pregnancy, and we should not do anything. But if true hyperthyroidism develops during pregnancy, then what are the causes? Okay, the commonest cause that we encounter is called transient gestational hyperthyroidism. So that is seen in up to 3% of the pregnant individuals. When this transient gestational thyrotoxicosis or hyperthyroidism is very severe, then it can be associated with recurrent vomiting, dehydration. We call it hyperemesis gravidarum. Okay, so hyperemesis gravidarum is very closely linked to gestational thyrotoxicosis. The second most common cause is possibly Graves' disease. Sorry for the spelling mistake here. The apostrophe should be after S. Other causes are very rare, like toxic MNG, solitary toxic adenoma, and some disorders which are very typical of pregnancy, like multiple gestation, hydatiform mole, and choriocarcinoma. Very rarely, TSH receptor mutation, which leads to hypersensitivity to HCG, which occurs normally during pregnancy, can also lead to hyperthyroidism. Moving over to our second case. A 28-year-old lady, G2P1. So it's a second pregnancy, presented at 11 weeks, occasional vomiting. There was history of similar episode in last pregnancy. She has tachycardia. There is no thyroid bruit, no thyroid-associated orbitopathy. The T3, T4 is quite high and TSH very much suppressed. So what is the possible cause? Now, as there is a similar history in the last pregnancy, there is no overt feature of Graves' disease. So our provisional diagnosis would be gestational hyperthyroidism or gestational thyrotoxicosis. Now, gestational thyrotoxicosis, as I said, can occur up to 3% of pregnancies. Many patients can have persistent nausea and vomiting beyond the first trimester. Sometimes there can be ketonuria, dehydration, and dyselectrolytemia. Typically, the resolution occurs by 28 weeks. So, if the problem persists beyond 28 weeks, then we should reconsider our diagnosis. And typically, there is no symptom before conception. And similar kind of episode can be seen in previous pregnancies, just like our patient, or in close relatives like sisters or mothers. Usually there is no goiter, but there sometimes can be very minimal goiter. There is no thyroid bruit, no thyroid orbitopathy, and uh, the antibodies are usually negative. And total T3, if you compare with Graves, is usually lower, but again, there is no clear-cut cutoff in this regard. If you do ultrasound, usually the thyroid gland vascularity is normal, but maybe slightly increased in severe cases. And how to treat these individuals? With beta blockers. So antithyroid drug is typically not required because it's a transient phenomenon. And by 28 weeks, all these features usually resolve. Now, in these features, there are some points which actually help us to differentiate this condition from the Graves' disease. Like before conception, there is no symptom, similar episodes in prior pregnancy, no goiter, no bruit, no thyroid orbitopathy, and negative antibodies. So all of these point towards the gestational thyrotoxicosis. Now moving over to another case. An 18-year-old girl, period of gestation is 12 weeks, presented with repeated and severe vomiting. There is palpitation, anxiety, and sweating for the last 6 months. So which is preceding the pregnancy. Okay, there is weight loss and there is tachycardia. There is some icterus. The goiter is diffuse, as you can see here. However, there was no bruit in this case. The thyroid function is very much elevated, thyroid hormone levels, and TSH is suppressed. SGPT and SGOT is high, and Barth-Wardowski score, which we used to diagnose this thyroid storm, it is borderline. And sorry for this, the thyroid bruit was there in this patient, sorry, which developed later on. No, initially there was no bruit, but later on with time, the bruit appeared and there was some worsening of liver function. So this is after 2 weeks, okay? However, the clinical features persisted. So the vomiting and some degree of dehydration, some jaundice was still there after 2 weeks of initial presentation. So what is this condition? This is, of course, Graves' disease. And although this is a patient with Graves' disease, there can be some presentation which overlaps with hyperemesis gravidarum, which is a typical presentation of gestational thyrotoxicosis. That's why we do not consider the presence of vomiting and other features of hyperemesis gravidarum as a point against uh, gestational thyrotoxicosis or Graves' disease. So, uh, Graves' disease can present with hyperemesis gravidarum like feature. Okay, so to diagnose Graves' disease, we need to have some points like diffuse goiter that is present there. Although thyroid acid orbitopathy is not there, if present, that can be one of the clues. And if thyroid receptor antibody is positive, just like our patient, that also suggests or rather diagnose Graves' disease. Moving on to our next case. This 26-year-old lady, again, G2P1. Graves' disease was diagnosed many years back, and she presented to us back in 2011. And there was a history of radioiodine ablation in the past in some other institute. Okay, the last dose was given in May 2011, and the LMP is 22nd of June. The patient was started on carbimazole 60 milligram. The doses were gradually reduced to 15 milligram. The patient was doing well. However, she stopped the drug 2 weeks before presentation, and she developed some features of heart failure. So, like orthopnea, palpitation, pedal edema, and some GI symptom like hyperdefecation. Now, here is an important point to note that this patient, she conceived just 1.5 months, that is just 1.5 months after I-131 dosing, which is not ideal. Okay, so this is a very important point to remember, that once you do a radioiodine ablation therapy, always instruct your patient not to become pregnant within the next 6 months. This is extremely important. This is for two reasons. Number one, that there is some uh, instability in the thyroid function just following the ablation. And number two, there can be some putative or potential of teratogenicity just after radioiodine ablation. So we always advise to wait for 6 months to have a stable thyroid function and then try for pregnancy. However, this didn't happen with this individual. So inadequately controlled hyperthyroidism is a contraindication for pregnancy. So typically, when a person tries to conceive, we confirm euthyroidism for at least 2 occasions over 1 to 2 months. And if the person is on antithyroid drugs, we typically ensure that she is getting the lowest possible dose of these drugs for biochemical control. Okay. Typically, we ask the patient to stop these drugs if the dose requirement is very minimal once they become pregnant. Like if the methimazole dose is less than 5 to 10 milligrams, then we ask the patient to stop this drug as soon as pregnancy is diagnosed. What is the reason? I will discuss later on. However, there are some situations where if you stop the drug in the just after detection of pregnancy, there is a high chance of relapse. So in those situations, we may not stop the drug. We can ask the patient to continue with methimazole or carbimazole, or we can switch to propyl thiouracil if the pregnancy is diagnosed in the first trimester of pregnancy. So what are the situations where there is more chance of relapse after stopping the drug when the duration of therapy is very short, that is less than 6 months. Then, if there is active thyroid associated orbitopathy or large goiter, if the dose of methimazole or its equivalent dose of carbimazole is more than 10, or uh, despite methimazole the TSH is suppressed and the thyroid associated thyroid receptor antibody level is high. So these are the situation where you would expect relapse once you stop the drug just after diagnosis of pregnancy. So in these situations, we typically do not stop the drug. We continue antithyroid drug in minimal doses. It may be methimazole or carbimazole, or you can shift to PTU. Now, which is the choice, we'll discuss in our later slides. Now, some points about iodine 131. It's, as I've said, that it is of course contraindicated during pregnancy, and we always, in a woman with a childbearing age, we always ask for a serum beta HCG level 48 hours before sending the patient for radioiodine ablation therapy, because there can be undiagnosed pregnancy, and as I've said, the iodine can have some teratogenic effect, potential teratogenic effect. This is something I've already discussed, that after radioiodine therapy, we should wait for at least 6 months for stabilization of thyroid function, and we should ensure that TSH remains less than 2.5. However, please remember that thyroid receptor antibody can remain elevated up to 1 year. Now, this has some important implication. Again, we'll discuss this later on. There are some concern that if the patient conceives immediately after radioiodine dose, there can be increased chance of miscarriage, aplastic anemia in the newborn, and possibly Edwards syndrome. Again, these are not very well proven. So again, coming back to our patient. Now, again, after starting, when the patient presented to us after stopping the drug for 2 weeks, there are features of heart failure, plus the patient had asthma, which was also uncontrolled, and she also is running a fever, and Bach score was more than 45%, which is suggest a likely thyroid storm. And if you see the thyroid functions, it's still not adequately controlled. However, there is some reduction of liver enzymes after starting treatment, but urine protein is positive. Okay. So in this situation, we did a fetal USG profile, a single fetus with good cardiac activity. The age was 20 weeks, 3 days, which is more or less corresponding. However, the fetal heart rate is high. This is something that indicates the transfer of thyroid receptor antibody to fetus, leading to the increase in fetal heart rate. Typically, I will discuss the cutoff later on, it's around 160. Now, fetal thyroid on USG is normal and the liquor is scanty. So, what are the indications of USG signs of fetal hyperthyroidism? Goiter, which can be picked up by a good ultrasonologist, as you can see here in this picture. There is the goiter here, and fetal heart rate, if it persists for more than 10 minutes, and if it is more than 160, and there is moderate variability, there is some acceleration without adequate deceleration, that indicates fetal hyperthyroidism. There can be features of accelerated bone maturation, where there is ossification of distal femoral epiphysis at 31 weeks. Okay, this is a very specific and predictive sign of fetal thyrotoxicosis. Plus, there can be IUGR, there can be congestive heart failure in fetus, which can be picked up by fetal echocardiography, and there can be hydrops or oligohydramnios. Now, these are the features by which you detect fetal hyperthyroidism. Okay, so the patient that we discussed, her fetus is having hyperthyroidism. Now, in our case, what are the problems in mother? She has uncontrolled Graves' disease, likely thyroid storm with high output heart failure in the background of asthma. And we should avoid the obstetric complications in this patient, which may include possible preeclampsia in this patient as suggested by proteinuria, and there is a risk of pregnancy loss. And the fetal and the other fetal issues are also there, and there are some potential neonatal issues as well in this individual. Like in this patient, thyroid receptor antibody is positive, and there are some features of fetal hyperthyroidism as picked up by ultrasonography. However, some fetus can develop hypothyroidism because just like TRAB, antithyroid drugs also cross placenta, and they can inhibit the thyroid function of fetus. So in some patients, if the dose of antithyroid drug is excessive for fetus, hypothyroidism can develop in fetus, so which can be detrimental for fetal growth and fetal brain development. Okay. Sometimes there can be central hypothyroidism after delivery because during fetal thyrotoxicosis or fetal hypothyroidism, there can be alteration of hypothalamic pituitary thyroid axis in fetus. Now, in a newborn, this inhibition of hypothalamic pituitary axis can persist for a considerable period, and that can lead to central hypothyroidism in fetus. There can be prematurity, IUGR, low birth weight, even stillbirth. Seizure disorders and neurobehavioral disorders are also reported. Okay, so these are the complex problems that can be associated with maternal hypothyroidism. Now, what are the medical therapies? We'll discuss those in more detail. Now, here lies the choice. First, that we know that there are some teratogenicity of antithyroid drug. There are some controversy regarding which one is better. Now we more or less have a clear picture. I will discuss that later on, that both the antithyroid drugs that are commonly used, that is on one hand methimazole / carbimazole versus PTU. And it has been seen that both the drugs can have fetal teratogenicity. However, if the hyperthyroidism remain uncontrolled, then it causes more problem to pregnancy as well as fetus. So keeping the mother grossly hyperthyroid is also not an option. So that's why we have to choose between these options. Now, there are many studies. This one is one of the most recent one. It has been seen that both the drugs, that is PTU and methimazole or carbimazole, cause fetal problems, teratogenicity almost to the similar extent if we consider the incidence. However, the birth defects seem to be a bit more severe with methimazole carbimazole rather than PTU. And that is the reason why some authorities recommend to shift to PTU in early first trimester as soon as pregnancy is diagnosed. Again, there is another study. This is from Korea. Again, more or less similar picture, bit more severe fetotoxicity with methimazole. Again, there is a systematic review and meta-analysis. You can see here the more severe fetotoxicity is seen with carbimazole or methimazole. Okay. So there are a conception that you can switch to propylthyrosol even before conception when the patient is trying for pregnancy to minimize the exposure to methimazole in early pregnancy. However, there is a problem. Propylthyrosol is a drug which has a rare but very serious side effect of idiosyncratic acute liver injury. And worldwide, the PTU, propylthyrosol, is the second most common cause of acute fulminant drug-induced liver failure following paracetamol. Okay, so be very careful regarding that. So we have to choose between many options, which none of which is ideal, but we have to have a decision based on the knowledge that we have as of now. So European Thyroid Association, they recommend that women who are treated with methimazole should be switched to PTU when planning pregnancy. American Thyroid Association says that you should not do this. You wait until the person becomes pregnant and then shift to uh, PTU. And there are some other authorities, more recent guidelines, they say you can continue with methimazole despite having a bit higher risk or more severe risk of hetotoxicity, because in general, the risk of hetotoxicity, if you talk about the absolute risk, that is minimal. Now, other than hepatotoxicity, there is another problem of shifting from methimazole to PTU. We know that there are some dose equivalents, that is 10 milligram to 15 milligram of methimazole dose is more or less equivalent to carbimazole dose of 100 milligram. However, it does not reflect the universality of application. That means that some individual, this conversion factor is like that, but in some individual, the conversion factor is different. So a person who is well controlled with methimazole or carbimazole, if you shift to PTU, there is a chance that the hyperthyroidism can become uncontrolled or patient can land with hypothyroidism. So that's an additional complexity, additional layer of complexity to this. Now, with all these complex things in mind, what we did in this particular individual, she was given oxygen, salt and fluid restriction to combat heart failure. PTU was given because there was thyroid storm. Because in thyroid storm, PTU is a better choice because it inhibits the conversion of T4 to T3 in periphery. So in these individuals, we started PTU despite in advanced pregnancy. Okay, verapamil was given as suggested by cardiologists. Particularly, we are unable to give beta blockers because of uncontrolled asthma. Alpha methyl dopa was also added, and inhalation therapy was added, and the patient was transferred with PRBC. And she was monitored, and I will come to the further to 4 weeks. It's not possible for 2 weeks for every individual practical, 6 weeks. Always keep T4 in trimester specific reference range. And an alternative I already discussed, that adjusted non-pregnant adult value of total T4. We can use that as well. We should keep free T4 or adjusted T4 just above the upper limit of normal. This is very important. In hypothyroid, we said that we should keep TSH within the normal range. But in hyperthyroidism, the target is obviously not TSH but T4. And second, T4, free T4 is not within the normal range, but just above the upper limit of the normal range or just around the upper limit of normal range. This is very, very important. Okay. And once the patient achieves target, then we can relax the monitoring maybe every 4 to 8 weeks. And if there is a normalization of TSH during monitoring, then you should always think that there is a chance of overtreatment. Always reduce the dose, because again, we do not want to induce fetal hypothyroidism. And that is the reason sometimes we wish to undertreat a pregnant individual a bit, so that I've said the target T4, free T4 is just above the normal limit. Now, why and when should do thyroid receptor antibody? Okay, so typically fetal TSH receptor antibody, the maternal TSH antibody, they start crossing placenta from late second trimester onward, and fetal thyroid start responding to TSH receptor from the same in around the same time period. So around 20-22 weeks. And the level of TRAB reaches equilibrium between mother and fetus in around 30 weeks, which includes the free transfer of TRAB through placenta. And the measure predicting the hyperthyroidism. And when the value is more than 3 times of upper normal limit. So our typical upper normal limit for most of the lab is 1.8 microgram per m. So if it is more than that, then it's an indication for close fetal surveillance. If the target is, if the level of TRAB is low on the other hand, it's on the very lower normal limit, then we try to minimize the dose of antithyroid drugs. Okay. Now, if a person who had done a TRAB level early in the pregnancy, and now in the period of 18 to 20 weeks, you find the TRAB has become negative. Now, then you should consider reducing your antithyroid drug drastically or stop it altogether. And another usefulness of TRAB I have already discussed, that it helps to differentiate between gestational thyrotoxicosis and Graves' disease. Now, if we summarize the medical treatment, Graves' disease during pregnancy, as I've said, you can continue with methimazole, you can switch to PTU. Ideally, TRAP should be done at diagnosis, and elevated, it should be repeated at 18 to 22 weeks. However, for the economic constraint, because these are very expensive tests, we typically do not measure in first trimester unless there are some diagnostic dilemma in differentiating between the Graves' disease and gestational thyrotoxicosis. So, if the TRAB is elevated between 18 to 22 weeks, then we always ask for close monitoring for fetal thyrotoxicosis. Okay. And the other treatment options, medical treatment options, we have already discussed during our in the last few slides. Surgery is something which is rarely performed nowadays during pregnancy. However, if there are some circumstances like there is reaction to antithyroid drugs, the patient cannot tolerate antithyroid drug, and of course the radioiodine therapy is out of question during pregnancy, so there you can plan for surgery. And the surgery is typically done in second trimester because it has been seen that there is minimal chance of fetal loss if surgery is done in the second trimester. And pre-op beta blocker and potassium iodide is given to stabilize the thyroid and to reduce the thyroid gland vascularity to help the surgeon. There is one condition, that is maternal hypothyroidism along with fetal hypothyroidism. Now, when this happens, sometimes, as I've said, that a person who underwent radioiodine ablation, say 8 months back, and now she became pregnant. Now, as I've said that after ablation, the high level of thyroid receptor antibody can persist 1 year or beyond. So if such a patient become pregnant, there is a chance, it's not a universal phenomenon, but there is a chance that the mother is hypothyroid because of successful treatment with radiation therapy and she is on levothyroxine. However, she is having a high concentration of thyroid receptor antibody, which is crossing the placenta and which can induce fetal hyperthyroidism. So this is a situation which is a combination of maternal hypothyroidism, which is being treated by levothyroxine, and the fetus is thyrotoxic because of thyroid receptor antibody affecting his or her fetus, his or her thyroid gland. And this is the indication where we use the combination regimen, that is levothyroxine to treat the mother and antithyroid drug to treat the fetus. So we give antithyroid drug to mother, which crosses the placenta and act on the fetal thyroid gland to treat the fetus. This is a rare situation, but we have to do it sometimes. Okay. So coming back to our patient after all this discussion, the patient became stable and discharged on propylthyroxine and methyl dopa with plan to subsequent conversion to methimazole if she stabilized, and asked to follow up after 4 years. 4 weeks was doing well. However, subsequently she took gynae consultation and delivered by LUCS. However, she was followed up closely postnatally with clinical features as well as thyroid function test. Okay. So other related issues before ending, I'll just discuss. One is neonatal thyroid problems. I have discussed few of them, that there is a chance of fetal hyperthyroidism because of persistent thyroid receptor antibody in neonate after delivery. Second, there can be chance of neonatal hypothyroidism because of persistence of antithyroid drugs sometimes in fetal circulation following delivery. Number three, there can be chance of fetal neonatal central hypothyroidism because of suppress of uh, hypothalamo-pituitary thyroid axis due to high thyroid concentration during pregnancy. So there can be many problems. So it's a mandatory that you should check the fetus and do a repeated thyroid function test after delivery and treat accordingly. This is a very tricky situation. I won't go into very detail of this, but we have a case report published in Indian Thyroid Society journal. You can look at it, that how the neonatal thyroid function test tend to fluctuate and how to manage those situations. Second is lactation. We often face this question. Lactation is, antithyroid drugs are generally safe during lactation. So if needed, you can treat with the antithyroid drug. However, to minimize the exposure, we sometimes advise to take the antithyroid drug just after a breastfeeding. But again, this is nothing evidence-based. Overall, it has been seen that the antithyroid drug is secreted in very minimal quantities in breast milk. So you should continue it. And please remember, radioiodine therapy is contraindicated during lactation because uh, lactating breast is one of the tissue which can actively concentrate iodine. So if you give radioiodine, so instead of thyroid, the breast will take up this iodine and the thyroid ablation won't be there. Instead, there will be permanent breast tissue damage. Okay. And in lactation, another important point, if you wish to do a technetium scan for diagnosis, you can do it, but you should stop lactation for 24 hours. But if you do an iodine scan, then you should stop lactation forever for that particular pregnancy or that particular lactational period. So with this, I'll end with some take-home points regarding fetal hyperthyroidism. Trimester-specific TSH must be assayed. TSH is subnormal. If it is there, then check for T4. The commonest thing is gestational thyrotoxicosis. However, Graves' disease is also common. Before radioiodine ablation, always do a pregnancy test 48 hours before the radioiodine ablation, ideally from the venous blood that is beta hCG level in serum in a woman with childbearing age. We should try to minimize early fetal exposure to ATD. What are the strategies that we discussed? There are some controversies in this, I do understand, because of the nature of evidence that we have. We should re-evaluate the need of antithyroid drug prior to pregnancy and as well as during pregnancy, because Graves is a situation, is autoimmune disorders, unlike many autoimmune disorders which tend to go into remission during pregnancy. So this is one of the situation where there can be some remission or complete remission during pregnancy. The woman may not need antithyroid drug until delivery. But again, this means that 6 weeks after delivery, there is a chance of flare. So be very careful regarding that. So if antithyroid drug is needed during pregnancy, we usually discuss with patient regarding pros and cons and do accordingly. Strict monitoring is a must because you should not induce fetal hypothyroidism, which is very much detrimental. And our target of free T4 is always in the upper normal range or just above the normal range. And appropriate fetal and neonatal surveillance is extremely important. So I'll end here. If you have any questions or comments, that's the most welcome. Thank you so much. Thank you.
Thank you, Rana. That was a masterly class, really. And
Thank you, sir.
very lucidly, it was very helpful. Now, Solil will do all this question answer and
Yes.
and the
Is there any
Sormista will just pack up the thing and give her opinion regarding any lacuna.
is there any question in the chat box? I think there is no question in the chat box.
দেখতে হবে দাঁড়াও।
No, I am seeing the chat box.
Hey.
There is no question.
একটা
Yes,
question
I have seen.
একটা ছিল মনে হচ্ছে।
না, এটা
Going
অভিষেক
on,
কিছু লিখেছে।
but no question is available here. Yes,
Hmm.
no, that is only good morning to all sir and madam.
Yes,
Nothing
that is by Abhishek.
that is very
Ah.
obvious.
কোনো কোশ্চেন আনসার নেই বাবা?
Very lucidly described the very difficult topic. In fact, this master class has two parts, hypothyroid as well as hyperthyroid. And Dana nicely covered all the aspects of these two different topics of thyroid dysfunction. Any question from the audience?
আমাদের মধ্যে তো গাঙ্গুলি স্যার তো কোশ্চেন টোশ্চেন একটু করে, আর আজকাল শিবেন্দু থাকছে না, শিবেন্দু তো খুব ইন্টারেস্ট নিয়ে করতো।
In fact, Rana, in
Yes, sir.
pregnancy, there is no